Hey everyone, this is Dr. Michael Asayag from the International Center for Limb Lengthening in Baltimore. This is an Antegrade femoral lengthening using PRECICE. It starts with an IT band fasciotomy to prevent knee contractures and hip contractures during lengthening. A 4.8mm drill bit to create a vent hole through which we'll put a suction tip. I mark the skin for the entry point of the nail and mark the osteotomy site, and then I pre-drill the osteotomy site using a 4.8mm drill bit that creates vent holes and that shows me the location of the osteotomy. Then I find the entry point of the nail at the piriformis fossa and confirm its position under fluoroscopy. An 11mm drill is used to perforate the canal, and a guide rod is inserted, and sequential reaming of the femoral canal is done from 8mm to 12.5mm, in this case for a 10.7mm nail. This is done very carefully, slowly, and with very sharp reamers to prevent fat emboli and pulmonary embolism. Once the canal is fully reamed, we use 3.2mm Steinmann pins at the lesser trochanter and around the knee to place rotational markers that will prevent malrotation by the end of the surgery. This is done very carefully and with the help of an assistant or an ankleometer to assess proper rotation. The nail is then advanced up to the osteotomy, which is then completed with an 8mm osteotome. Translation of the osteotomy confirms completion, and then the nail is advanced to the appropriate depth. We use the jig to insert the proximal 5mm locking pegs and confirm their position under fluoroscopy. We then use a perfect circle technique to insert the distal 4mm locking pegs, in this case because this is a 10.7mm nail. We use pegs rather than screws because their core is larger and they're stronger, and they will allow a little bit more weight bearing than fully threaded screws. At this point, the surgery is basically over. All we have to do is remove the rotational markers that we confirm were collinear at the end of the surgery, and then we mark the position of the magnet inside of the rod by fluoroscopy, and we place a very thick purple line to which we align the external remote control. It's super important to verify that the mechanism of the rod works before leaving the OR, because there is still time to swap it out, because about 1% of those rods do not work in surgery, and that's a catastrophe when that happens. I love to use a plastic surgery style closure with buried stitches underneath the skin. It yields a very nice cosmetic result.